Hello, everyone. Hope you hear me clear. Welcome to today's EURASIP webinar. My name is Mauro Costagli. I'm an associate professor of applied medical technical sciences at the University of Genova, Italy, and member of the Biomedical Imaging and Signal Analytics, that is BISA, Technical Area Committee of EUSIPCO. This is the very first webinar of a new series organized by our Technical Area Committee, and other seminars of this series will be announced in the weeks to come. Today's speaker is Dr. Paulo Bosco. Paulo is a researcher at the Stella Maris Hospital and Research Center in Pisa, Italy. Since 2008, he focused his research interest in applying the methods of physics in medical image analysis and processing. He developed expertise in processing multimodal imaging of different organs and tissues, and developed machine learning approaches for the detection of novel imaging biomarkers of pathologies and conditions like breast cancer, Alzheimer's disease, and autism. He is now principal investigator of an ongoing study funded by the Italian Ministry of Health on the assessment of the benefits of cognitive training as well as physical training in populations at risk of developing dementia. So I'm sure you will enjoy his talk today. Please be aware that this webinar is recorded. At the end of Paulo's talk, I will moderate the question and answer session. Please raise your virtual hands and feel free to make questions or type your questions in the dedicated space, the chat, okay? So thank you very much again for joining, and Paulo, please.
Okay, hope you can hear me clearly. Okay. Great.
Yes.
So, hello everyone, and thank you very much for inviting me to give this webinar to the EURASIP community. As a physicist, I would like to propose you some thoughts about measuring pathology and normalcy in medical image analysis, and in brain MRI in particular. The perspective I would like to give you is about how, starting from the imaging signal, it is possible to face the various sources of noises and variability and to extract meaningful information for the detection of biomarkers of pathology. Let me start from the very beginning. I beg your pardon. But let's remind us what we mean by the concept of measure in general. The definition of a physicist is that by measure we mean the quantitative assessment of an observable, and this concept entails the construction of more complex instruments, such as theoretical models, statistics, of course, metrics, and the definition of what is signal and what is noise. So if we want to address the research of new biomarkers in neuroimaging from the physical point of view, however, we must take into account the big differences that there are between the scientific method in physics and the clinical world. Just to give you some example, in physics, the observations could be both direct and indirect. In addition, the observation derived from previous experiments can be used to provide better estimates on new theories. But on the contrary, in medicine, there is only the clinical direct observation, so we cannot use the very same approach. Also, the approach to the theory is very different. In physics, the observation is described by one or more models, depending, hopefully, I would say, on a few free parameters, under the assumption that even complex phenomena can be described by relatively simple models. In clinical world, instead, there are no comprehensive models due to the high complexity of the subjects, with enormous variability, different clinical histories, with subsystems that interact reciprocally in a non-negligible way. So the world is clearly different. Furthermore, in physics, it is possible to perform experiments as we wish. These experiments must be reproducible and coherent with the model to confirm the validity. The typical paradigm which models the output as a signal plus a noise factor, so quite simple. In clinic, the experiments could rarely be performed. It's very difficult and also expensive, of course. And the only possible approach is in vitro experimentation and clinical trials, where the typical assessment is based on the improvement or not improvement of the patients, with a reproducibility that is difficult to achieve. Also, the data analysis has different challenges. Because in physics, we can design filters to extract a signal from noise. Since we have well-defined experimental designs that can be well characterized, starting from that, it is possible, for example, to refine the estimation of model parameters and to also provide an estimation of the uncertainty. In clinical world, the data analysis is designed to determine an improvement probability of the subjects on very specific disease symptoms with strong a priori assumptions on the models and with a lot of difficulties in estimating the errors. So let's dive in a specific field of medical image analysis, in this case, brain MRI. So the actual sign in this case is a 2D or 3D matrix of numerical values. In this matrix, we can say that if there is a pathological sign in the signal, this is immersed in a normalcy background. For most of the neurological pathologies, we lack a real theory. So the pathological differences in most of the cases must be deduced by group comparison of images of healthy versus pathological subjects. And of course, we are already making assumptions. In particular, we are assuming that the pathology markers are common in all the individuals affected by the pathology under study. Not only, we are also assuming that out neurological disease can be described by continuous process that bring the subject from the normal to the pathological condition. So these are very strong assumptions. But in brain MRI imaging, which are the sources of variability and how can we identify the noise? Well, of course, there are many sources and many noises. First of all, there is the acquisition noise. The image acquisition noise can be easily quantified and can be traced back by multiple factors like scanners, electrical noise, and changing or bad acquisition conditions. In MR imaging, for instance, the electrical noise is due to the thermal movements of the electrons of the acquisition system. Another source of noise is the capacitive coupling of the subject to the coils used for the radio frequency signals that causes dielectric losses during the acquisition. These sources of noise yield a Gaussian noise component to the signal, but the following steps of imaging reconstruction that use the inverse Fourier transform modify the probability density function of the intensity in a distribution of Rice. In other cases, the constant magnetic field, B0, which is the static magnetic field required to orientate the magnetic momenta of the hydrogen atoms of the subject during the radio frequency sequences, can be spatially non-homogeneous. And also its gradients, which are necessary to the spatial reconstruction, can also show temporary abnormalities. For instance, these abnormalities can be due to the presence of metallic objects near the magnet, like inserts in the mouth of the subject for odontoiatric treatments. And this alteration can significantly alter the field. In addition to the acquisition noise, we must consider also the physiological variability. Each subject has its proper characterization with variables that can be considered as confounding variables with respect to the pathology. For example, age, the sex, the education, the general anamnesis. And we also must be aware that these variables can have non-negligible interaction with the pathological pathway itself. Inter-individual differences, even within subjects belonging to the same clinical cohort, are often bigger than those we wish to measure by the biomarker. So it's a very difficult situation. These differences are due to many factors, just to mention some, genetics, clinical history, habits, environments. So we must be aware that these elements strongly affect brain metabolism and structure. And as previously said, since there is no quantitative theory on the pathological signal we are trying to assess, this signal has to be defined starting from group comparison and group differences among training datasets, typically healthy versus pathological subjects. So if the subjects are not properly selected, the whole analysis can be biased or be significantly impaired. So the gold standard noise is the noise related to the choice of the inclusion criteria of the subjects of the cohorts included in the training process. Ideally, this group should be pure with respect to clinical status and unambiguous. But in the common clinical world, in particular regarding this particular kind of disease, the purity of the cohorts cannot be assured at all. Just to mention an example, the diagnosis of Alzheimer's disease is still subject to a 30% of error. So if we consider the class Alzheimer's disease as a diagnostic pure group, we are already doing a very huge mistake. So we cannot assure that the purity of the group we are using to feed our pathological signal extraction. In addition to that, we must consider also the data processing noise. The data processing noise is not noise per se, but rather the expression of uncertainty in the biomarker accuracy due to the many possible choices we do in the selection of algorithms and parameters involved in the signal extraction. Indeed, as we will see in the next slides, the biomarker extraction implies the use of many algorithms and filters which are prone to artifacts. So the image processing, if not properly chosen and performed, can significantly alter the signal, yielding a suboptimal performance. In addition, since it is not always clear where the significant information lies, artifacts induced by improper image processing can be difficult to assess. So the choice of the algorithm must be carefully planned, independently tested, and they often require an extensive optimization process based on biomarker extraction on the training datasets. So just to recap, we have brain MRI of healthy and pathological subject with neurological disorders. And what do we aim at? Well, we aim at extracting quantitative features from the medical images through data characterization algorithms. And we look for features that have the potential to uncover disease characteristics that fail to be appreciated by the naked eye of a neuroradiologist, or at least that may quantify some neuroradiologist qualitative findings. The underlying hypothesis is that the distinctive imaging features may be helpful in diagnosis, prognosis, and predicting therapeutic response, thus providing valuable information towards personalized therapy. Let's have a look on an example of MRI brain image modality. This is a T1 weighted brain image. You can see 3 axial different slices of a human head with a spatial resolution of 1 millimeters cubed. In this MRI sequence, it is very clear the localization of gray matter, white matter, and cerebrospinal fluid, which is black. We know that the gray matter is constituted by the neuronal body cells, while the white matter is constituted by the axonal connections. So in this modality, it is easy to quantify the volumes of gray matter structures, the thickness of different cortical areas, and the general condition of neurons from the anatomical point of view. From the signal point of view, our T1 weighting MRI image is a 3D array of numerical data, where each volume element is called a voxel. And of course, each voxel can be identified by its XYZ coordinates. In this case, the numbers are more than 250 elements per each direction. So let's choose a very simple example and have a look on the entire signal extraction process. In this example, we ask ourselves whether it is possible to distinguish Alzheimer's disease subjects from healthy subjects just from their T1 weighted MR image of the brain. This is a typical workflow for the neuroimaging biomarker extraction. So the first step is the quality check. As previously explained, many are the sources of acquisition noise. So reliable biomarkers need relatively high quality images. So a quality check is needed, of course, to drop out from the analysis very noisy images or acquired volumes showing strong artifacts. The second step deals in all the aspects necessary for a statistical group analysis, the most important of which is the space normalization, which is the concept of image registration. I'll be back to that later. This is necessary to guarantee structures alignment of all the subjects belonging to the considered group. Space normalization is the first important step to tackle the difficult problem of inter-individual structure variance. Then we also need intensity normalization to assure intensity group conformity. Indeed, if we consider T1 weighted MRI imaging, the intensity that describes the relaxing time of protons is expressed in arbitrary unit strongly depending on acquisition condition. Even the same protocol on the same scanner on the same subject can't assure intensity conformity in a new acquisition. After the space and intensity normalization, there are, of course, many possible choices in biomarker extraction process, but a common strategy consists in a region of interest ROIs extraction. This choice can be guided by clinical information about the most commonly affected areas by, for example, the neurodegenerative process involved in Alzheimer's disease. For example, we already know that the medial temporal lobe and the hippocampal structure is for sure involved in the degeneration of Alzheimer's disease. So we can choose some region of interest focused on these brain structures. The further step is the characterization of the extracted region of interest. Intensity, texture, or geometrical properties can be extracted. For example, in brain cortex, one of the most common measure is the measure of cortical thickness, which is a very sensitive quantity for neurodegenerative processes. The last step is the classification stage. So an appropriate algorithm can be trained on the extracted feature space to classify new subjects or to perform group comparison by statistical analysis. So this is the most common pathway. Of course, there are many variants, but most of the cases can be covered by this scheme. In this case, I will show you an example with an initial quality check, some noise removal, a spatial registration step, an intensity normalization step. And you can see that on the right column, I reported every time for each step which kind of source of variability or noise we are trying to correct or to take into consideration and limiting. So, for example, the extraction of a region of interest face the problem of physiological variability. And of course, classification and statistical analysis are affected by the so-called gold standard noise I mentioned before. So many sources of variability and noises, but we are processing the images, so we are also introducing data processing noise, which depends on the choice on the parameters and algorithms we are going to make. Just a few examples in this workflow. I'll bring you here an example of noise removal. One of the options to perform image denoising also in MRI domain is to pass from the image domain to the frequency domain, in which the continuous component is in the center of the image and the high spatial frequency elements are close to the external frame. In this example, a wavelet domain was chosen as frequency domain, so we can describe the signal in a new base, the wavelet base. Wavelet-based denoising methods for MRI are quite common in literature, since wavelet domain processing has many beneficial properties compared to the classical image domain processing. Through the wavelet transform of the image, we gain access to a very sparse hierarchical representation of the image and the signal, where most of the information is contained in very few high magnitude coefficients, and the remaining low magnitude coefficients can be related to the noise present in the image. So by altering the low magnitude coefficients and by applying the back transform to the image space, it is possible to have a very good denoising effect in this kind of images. Here you can see the effect, I hope you can see well, the effect of a denoising filter on a T1 weighted MR image of the brain. The noise reduction is beneficial in the identification of the boundaries between gray matter and white matter. You can observe the reduction of the noise mainly in the white matter in the center of the image. Then, of course, we need, since we are reasoning on group comparison, we need to put all the brain of the cohort in a common space to obtain meaningful group comparison of brain structures. In this case, of course, we are reducing the effect of the physiological variability among the subjects. But what is the registration process? Here you can find the main scheme of an image registration process. The basic is that there is an input data which consists in two images. One is defined as the fixed image, fx, and the other one is the moving image, mx, and x represents, of course, a position in n-dimensional space. The registration is treated as an optimization problem with the goal of finding the spatial mapping that will bring the moving image into alignment with the fixed image. The transform component, the Tx, represents the spatial mapping of points from the fixed image space to the points in the moving image space. Of course, they have different grid, they are different matrices. So we need the interpolator. So the interpolator is the instrument that is used to evaluate the moving image intensities at non-grid position. And of course, we need to measure the difference between the moving and the fixed after applying the transform. So we need a metric, and the metric component is called S, F, M dot T. This metric provides a measure of how well the fixed image is matched by the transform moving image. This measure forms a quantitative criterion to be optimized by the optimizer of the search space, so defining the parameters of the transform. So at each iteration, the metric is evaluated until a certain minimum value is obtained. Here you can find the result of a registration process of a T1 weighted MR image to a standard template, which is chosen as a common space for all the subjects of the study. To map the main brain structure by matching position, orientation, and size, a 12 degree of freedom transformation was chosen in this case. In this case, the metric chosen was the cross correlation, but there are, of course, many other possible choices, such as mutual information, structural similarity index, and other measures derived from information theory, if you want. Then, after space normalization, we need intensity normalization. As already mentioned before, T1 weighted signal is not a quantitative measure, and to obtain a good intensity normalization, we need a region of interest containing, for sure, cerebral spinal fluid, gray matter and white matter. Here is the box in red. In this box, we can identify in the gray histograms some clusters which correspond to the cerebral spinal fluid, gray matter and white matter signals. These three clusters are then matched to the corresponding same material mean levels of the reference image. And we consider this as fixed points through which a cubic spline is fitted. This nonlinear intensity normalization pairs the free mean cluster intensity in the region of interest between each subject, and by using the template as a reference image, we can extend the mapping to the other gray levels by a smooth piecewise polynomial curve to have all the subjects with the same intensity reference. Here you can appreciate the effect of gray levels normalization using these procedures on the histograms before and after the intensity normalization steps. You can easily observe how after intensity normalization, the peaks of cerebral spinal fluid, gray matter and white matter get much closer, providing a more homogeneous signal for the following steps. Next, we can, once we intensity normalize our signal, we can extract intensity features. So, for example, in this case, we are talking about Alzheimer's disease, so we can focus on regions of the medial temporal lobe. The hippocampus, for example, is part of this brain area. So we can identify a volume of interest, like in the slide. I select the area involved, so you can see the original signal of the in this region of interest centered in the right hippocampus of this subject, and you can see the original signal in the red box, and then we can apply different filters. This time not in the frequency domain, but in the image domain, to elucidate textures, edges, and patterns. In this example, the results of the identified volume of interest are shown for Gaussian, average, entropy, range, and standard deviation filters. And starting from the top to the bottom, there are the range of the size of the filter is increased. So, for example, for Gaussian filters, you can see that the blur increase starting from the top to the bottom. And you can see in this representation that starting from the original image, we can elucidate different patterns on our region of interest. So once we process the signal this way, we can use classification or statistical analysis to be able to classify the group. I do not enter into details for classification. In this case, random forest classifier and support vector machine classifier were used. But I'm just giving a glimpse of what the results are. We can see here the importance feature map reporting which are the most important voxel for the decision of a random forest classifier to classify the T1 weighted brain MRI of the pathological subjects with respect to the healthy subjects. And as you can see, most of them are located in the hippocampus area, which is the brain structure, which is well known in literature as playing a pivotal role in memory. Once we obtain the most important region involved in the pathological process, we can also evaluate how well we can classify single subjects. So in these plots, you can see the distribution of a continuous classification index obtained through a support vector machine classifier, which ranges from -1 for the most pathological subjects to +1 in the healthiest subjects. Importantly, here I reported also the distribution of two more classes, which are called MCI-NC and MCI-C. MCI is the acronym of mild cognitive impaired, which is a condition of mild symptoms, mild cognitive symptoms, of course, that may lead to overt dementia or stay stable in time. By separating the MCI cohort in converting and not converting, so MCI-C are the converting subjects with respect to the MCI-NC, which are not converting, in a 3 years time frame, we can observe that the subjects who convert to dementia within 3 years obtaining their T1 weighted MR image, a classification which is much closer to the Alzheimer's disease subject with respect to the mild cognitive impaired that remains stable. So the extracted biomarker in this case is capable not only to say something about diagnosis, but also say something about prognosis. Going back to our initial question, can we distinguish AD subjects from control people by their T1 weighted images? Well, the answer is yes, quite well, by a very standard approach. And with this approach, we can reach 90% of sensitivity and more than 90% also of specificity. So they are quite nice performance. Just to mention what is going on in research, in this research field, in the recent years, deep learning techniques started to be applied in medical image analysis also. Deep learning methods intrinsically embed most of the elucidative steps, since in principle they can handle the signal from raw data to classification by elucidating the most important features autonomously. However, I would say that many challenges are open. So just to recap a bit, I would say that starting from the last decade, medical images are no more considered just as pictures observed by physicians and neuroradiologists. They can be properly treated as signals, and as such, they can be handled with many of the techniques developed in physics for signal analysis. As shown, we can extract a large amount of quantitative features, both anatomical. I stayed in this talk just in the anatomy, but of course, MRI technique can provide information on many other aspects, such as cerebral blood flow, functional information with the Ball signal, also information about connection of different brain areas with diffusion technique and many others. And we can exploit signal filtering, so the technique we can commonly use in signal analysis in both frequency and image domain, as shown. Of course, there are many sources of variability that can hinder this possibility. Acquisition noise, variability, physiological variability, and in particular, in the case of difficult pathologies with not known etiology, the gold standard noise. We can handle many of these sources of noises, but we must keep in mind not to introduce other sources of variability. So in this case, it is always a good idea to perform the analysis with maybe at least a couple of free algorithms that perform the same task, maybe in a different way, and use this multi-approach to validate the findings. And I will say thank you for your attention.
Okay, thank you, Paulo, for your very nice presentation. Can you hear me?
Yes, sure.
Okay. So if there are questions from the audience, please either raise your hand or type your questions in the Q&A box at the bottom of the window. If there are no questions, actually, I have a question. So you presented an approach from the standpoint of radiomics, say machine learning. Today, it seems that a very promising approach is deep learning. Can you comment on this?
Yes. Okay. Let's start from this slide. As already said, the deep learning approach is, of course, powerful. There are many studies showing, for example, in this very same example, that a convolutional neural network, deep neural network, can reach similar and even better performances in the classification task, for example, for distinguishing Alzheimer's disease subjects and controls. There are, of course, many issues open. I have a slide. Okay. Well, of course, the future of this kind of analysis is in deep learning. There is no doubt about that. Probably also the clinical input will be less and less relevant. I'm talking about the selection of region of interest that we usually perform to simplify the problem. You saw that we chose, for example, region of interest centered in the medial temporal lobe for the solution of the problem of Alzheimer's disease. So this will not be necessary anymore by using this kind of network. But even though this kind of approach can overcome the problem of, for example, maybe denoising, image registration, selection of region of interest, we must be very careful about the training cohorts. They need a huge amount of data to be trained. And of course, cohort representativity is crucial. Here I report in this backup slides a famous paper reporting that this kind of approach was very powerful in distinguishing dog and wolf, just by providing general images of dog and wolf. But then if they were fed by, for example, husky images, these kind of systems were easily tricked and they classify the husky dog as a wolf. And by looking with some technique on what the classifier uses really to distinguish dogs by wolf, in many cases it was using the snow in the background. So we must be very careful in our field to have a good representative cohort in the training set, because of course there still are this kind of source of variability. One example is we provide, for example, to the classifier MR images coming from different imaging scanners, for example, with different manufacturers. We know that the combination of manufacturers and coils can impact the signal in the T1 weighted images. And this kind of systems are powerful in distinguishing the images, but maybe if there is a not good balance in the cohort representation, for example, we have an imbalance in the representation of healthy subjects in one center with respect to pathological subjects in another center, these systems could be impacted and maybe can provide wonderful performances, but they are not looking at the pathologies, but they are looking on the disbalance, so in characteristics which are not related to the pathologies. So there are many papers showing that this can be a huge problem. So we must be careful.
Thank you. Yes. And we have a related question in the Q&A section. I don't know if you, Paulo, want to read it yourself. If you cannot, I read it for you, or I read it for the rest of the audience. It's a question from Akhtar, and he asks, what should be the engineering approach to machine learning, especially in the area of biomedical signal processing, due to the recent hype in AI, as we mentioned also already in this first question. Okay, so could you read the complete question?
No, I can't because I'm in presentation mode.
I see. So basically, the question continues. Due to the recent hype in AI, many engineers are tempted towards this area. However,
yes,
at the end, they become slaves of developed models instead of developing new solutions.
Yeah, okay. Yeah, this is a very common problem, I would say. And in AI field, I have some experience on that. The first risk is that every time a new powerful instruments or tools or new network architecture comes out, there is a temptation to just try it on our data. This is very risky. In our field, it's very risky. I can mention to you many published papers, in which it is clear that even good results are not real, and this is a problem because it is quite clear that there are one of the most important factors is the site acquisition effect. These images are very affected by the system, how the system is designed. Each manufacturer has its own reconstruction methods. Sometimes there are also some filtering which are not communicated to the customers. So we have we think we have raw data, but it is not actually true. So just by applying blindly very powerful method does not provide you very good results. Another thing I would say is that The problem of these very powerful systems is that there are emerging techniques, but they still lack explainability in many cases. Once it is not crucial to, if we are just classifying dogs and wolves, it's not a real problem. But if we are telling one patient to take a new drug or not to take a new drug, this is a very different field. So even clinician doesn't trust the results. So we need to tell them, okay, the system tells you that this subject maybe has this pathology, but if you do not provide evidences on what part of the image are involved in the decision and they are meaningful, they will not trust you.
Okay.
And they are right, I would say.
Yes. So, well, if there are no other questions, I think we can thank the speaker for his very interesting talk. It's very good food for thought. And so it was a pleasure to chair this session. And I hope to see you at the EURASIP, at the next EURASIP webinar.